Hello, welcome you to the IMS Myofascial Pain webinar series. Today's topic is the new anatomy and myofascial approach to knee pain. All of the series presenters specialize in myofascial pain, and their presentations are meant to spread knowledge about this condition, the leading cause of chronic pain worldwide. The series will educate participants about myofascial pain diagnosis, treatment methodology, and scientific research. You are invited to go ahead and write your questions in the chat box during the presentation, and at the end of the presentation, Dr. Hartz will address those questions. Today, our speaker is Dr. Renee Hartz, who graduated from Northwestern University, the Feinberg School of Medicine with honors, and became one of the first 12 women cardiac surgeons in the world. She also had many other firsts for a woman in surgery, including being invited to speak at the first National Conference on Women, the first woman to apply for and receive a training program in CT surgery, and most important to her, being the first pregnant CT surgeon. She was in labor with her first son while making morning rounds on the chairman of surgery service, and with her second son just after completing a coronary artery bypass procedure. Dr. Hartz mentored hundreds of medical students and residents and received numerous teaching awards during her CT surgery career. Always curious and interested in new science and medical ideas, she later decided to leave surgery and did locus tenens emergency room work for several years before being recruited to be the medical director of a large chiropractic health and wellness clinic. Dr. Hartz has close to 100 published papers. Her decision to explore myofascial pain treatment was purely accidental. She was in Wyoming when she noticed a copy of the Trigger Point Therapy Workbook. It was recommended for all orthopedic surgeons, and it opened the door to myofascial pain and treatment. She was hooked and began to explore the field as soon as she returned to Chicago. Subsequently, she became the medical director for the Chicago Center for Myofascial Pain Relief, where she works with the owner and founder, Mary Biancalana, a kindred spirit. Together, they have developed multi-modality drug-free trigger point therapy.
Wait. Now you're live. Thank you, Ray. Now it's on.
Thank you, Ray. I know that some of you know who I am. And from my bio, you might find it very interesting. And I've been asked the question many times, how does a cardiac surgeon end up in a myofascial treatment center? And so I'm going to try to show that to you. I also would like to point out, although it says contributions by Mary Biancalana to this topic, this is definitely a joint effort, and we have worked now for over 5 years, refining, expanding, adopting new procedures, learning about other things that are on the horizon, so that we are a unit doing this therapy. And I have Mary to thank for getting me into this practice. So, 1990, cardiopulmonary bypass and cardiac arrest. Why could we, as a team, put a patient on the heart-lung machine within 9 minutes of reaching our emergency room? The answer is obvious if you look at this slide. We knew the fascia. We know that the femoral vessels are a third of the way between the pubis and the iliac crest. And we knew where to make that cut down. One has to remember these patients were near or in cardiac arrest. There's no way to feel for the femoral vessels. So my point I'm making is that as surgeons, we were more fascist than any other specialty. And that's how it all started. So here it is. Here's the example. Did we really understand where all those muscles were, where the sheaths were at that point? No, but we knew if we made that incision in the correct spot, we would approach the femoral vessels, and above the inguinal ligament, they're the common femoral vessels, and get wires into the artery and vein and get that patient on the heart-lung machine very quickly. Several people survived this experience. It's amazing. But I'm saying we're talking about new anatomy. Who am I kidding? This is Andreas Vesalius. He drew this in 1543. I'll tell you a little about him in a minute. But this was my first foray into what is a myofascial unit. Long before I read both of the Stecco's work, this Latissimus dorsi is really literally attached to the periosteum of the humerus in this location and refers to the elbow frequently. I was lucky to have found that picture so long ago. So we're talking about the International Myopain Society. We're talking about a big meeting next June, and I encourage you all to consider attending this fantastic meeting. I'm sure that you've learned from Dr. Stecco that this is the oldest medical school on Earth. And Vesalius was a 16th century anatomist and physician, a professor at the University of Padua, where we will meet in next June, and is considered the father of modern human anatomy. So we are just now getting back to what was called modern human anatomy at the University of Padua in 1543. There's some question about my first presentation to the National Association of Myofascial Trigger Point Therapists, invited by Mary, of course, was in 2017. I had been working with her for about a year. And I read this paper by a physical therapist, massage therapist named Paul Ingraham. And these were his conclusions at that time. Despite all the brilliant scientific work by Gimberto, by the Steccos, by Schlepp, by Chaytow, trigger point therapy is experimental. The science is shabby. Using trigger point injections is like using a bazooka for a mouse. Most importantly, good trigger point therapy is hard to find and define. And I took serious issue with that question, but it drove me, and at the end I'll show you my conclusions from that. But that's how it was when I started. Then in 2019, Ingraham started to change his approach, and I actually happen to love this slide because of all the pains, algopathy, allodynia, chronic regional pain syndrome, you name it. Really, there are three types of pain: nociceptive, which, as you know, is at the tissue level; neuropathic, which is what carries the signal to the brain and the central nervous system, and we're going to get to that in a minute. And then there's other, and other overlaps. And the patient, I do not personally like the visual analog scale ratings, but they're phenomenal for treating a patient and then changing the score. In other words, a patient comes in with a 7 and ends up with a 3. I think that's fantastic. From my own perception and my preliminary evaluation, I like to look at it more like this. The patient, you can look at their face and see where they fall in this scheme. Now, something phenomenal happened just 2 weeks ago. Phenomenal. And reading, I guess we put it away, but Dr. Chaytow and Schlepp's book, there's a chapter by Frank Willard, who spoke about skin sense and visceral sensation. Now, here it comes this year, just 2 weeks ago. These two scientists got a Nobel Prize in medicine for discovering the biology of the senses. Basically, many of us have known, and from all the big science work that you have done, how the signal gets to the brain. We have not known what is the light switch. And this is what these two gentlemen did brilliantly. So I'm not going to go too far into this, but basically it's all about the neuromuscular junction. So these two men discovered the biology of the senses by studying the neuromuscular junction. In muscle fibers, you all know that every single fibril has an NMJ in the middle, in the center of the structure. And when I do my videos, I'll show you why that becomes important. So Artem Patapautin, I'm going to call him, discovered 2 ion channels, so piezo receptors. They were ion channels, so those are receptors. Whereas Dr. Julius, for years before him, was working on the genes responsible for the pressure touch sensation. By the way, piezo means touch or pressure in Greek. I'm not going to go into all this basic science, but it's very important that we now know, we all know, using a capsaicin model, Julius found the receptor for that pain from the capsaicin, which is brilliant. Another of my pet peeves is this question of skin. What is skin? Our anatomy books to this day, Gray's and Grant's anatomy, say skin is the biggest organ. Fascia is not even listed as an organ system. Skin is so important, and it's everything above, really, the deep fascia that you all talk about. Dr. Carla Stecco's book does not include the epithelium. So I want to show you, this is a very important slide to me coming up. If you look at this, I don't know if the arrow shows up, but the epithelium, The nerve sensors do not reach the epithelium. Epithelium, the purple part, is what's called the stratum corneum. That's the pigment layer. Now, beneath that pigment layer, the skin in every race the dermis is the same in every race. It's the same color. It's a whitish pale. And that's what we suture. That's what holds sutures. But again, these skin fibers these sensation fibers, the neuromuscular junction is way beneath the epithelium. The epithelium is a tiny part of the skin. But still, the skin, I do not believe, is in any sense the largest organ, despite all its subdermal components. If you add up all the fascia, and especially if you include bone with fascia as connective tissue, far outweighs the amount of skin we have on our bodies. And I'm open to any suggestions or arguments about that issue, but I felt that way ever since I've started surgery. So we have 4 tissues: epithelial, which I just showed you is minute, muscle, and epithelial. Do they really have pain fibers? Are there neuromuscular junctions in those? Or are there just transmitters that reach the muscle? On the other hand, connective and nervous tissue goes back to my Ingraham slide with the 3 types of pain. These are incredibly well innervated, especially the fascial components. This is an aside, and this is a prequel to what I'm going to present in Padua next June. But this is something that is very, very recent for us. And even if you notice this normal picture of skin here, again, in the epithelium, there are no neuromuscular junctions, no nerve fibers. This is a normal skin biopsy, and all these lines represent subdermal nerve fibers. And just, again, this is just a preview for you. Here is a patient of ours with small fiber neuropathy due to fibromyalgia. There are almost no small fibers. And we're finding this more and more in the rheumatoid conditions, the autoimmune conditions, especially in the fibromyalgia patients. And I hope to update you all on that next June. We're doing this routinely. There it is. There's the latissimus attached to the humerus, periosteum. And if you look at this, this is from the front to the back, but you'll see all the attachments from the latissimus to the spine and ending here. That's why these patients sometimes get elbow pain. And several major athletes in Chicago have been operated on for elbow pain who actually ended up having latissimus treatment in a myofascial clinic and finally really got rid of their elbow pain. So at least in America, the 10 quotes most common causes of knee pain are what you would think: bursitis, IT band, anterior cruciate, all these other things that we all know about. But I'm going to strongly question this issue of poor ankle mobility and replace it with something else. And also the issue of osteoarthritis. Bone has nothing to do. I don't know why this condition is called osteoarthritis. There's massive amounts of connective tissues in the knee. As a matter of fact, I even read recently that knee is now considered to be the biggest joint. I always thought the SI joint was, but when we really get into the anatomy and treatment of the knee, you'll see why I have this opinion. This is what's really, 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 really tragic. And it's getting worse. 25% of American adults and adolescents have knee pain. We spend $3 billion a year now on arthroscopic procedures. This also has a tremendous global prevalence and incidence, at least 16% worldwide. Very interesting phenomenon is this next issue. By country, the amount of knee pain varies. Look at USA has 130 per 10,000 patient years. UK has 315. Look when we get over to Japan. The farther east, the more knee pain. The more knee pain. Now, it turns out that 80% of Japanese are flat-footed. And there's a tie-in to that with what I'm going to tell you about poor ankle mobility. This is tragic. So almost 1 million hip and knee replacement surgeries are performed in our country annually. I hope it's not that way the rest of the world. Most common orthopedic procedure today. It's estimated by 2030, total knee replacements are projected to grow 673%. And what's even worse, and this is the most important of these slides, the University of Texas, this is brand new information, predicts that surgeons will soon be doing nearly 1 million knee replacements every year on patients as young as 45. These patients had barely had a chance to use their knees. How can 1 million of them have worn their knees out? And we feel very strongly about this. Every patient gets a very thorough evaluation, and many patients that present here have their feet as a problem for their knee pain, and we'll get into that. So up to this point, myofascial pain, and something that we're going to get into, which is called Morton toe a little bit later, causing knee pain. So what is new anatomy for us today? This is it. There are all these programs. You don't have to carry 200 pounds of textbooks to go to medical school or college anymore. It's all right here. And these two programs, Complete Anatomy is the most recent Elsevier, but I have to pay a licensing fee to use this. And this one, the Visual Anatomy, is a Google app for $3, and literally the user will be able to go through these and see every insertion, every origin, every motion of each part of the muscle. And I strongly recommend that anybody that's going to take Dr. Carla Stecco's courses in June get this app and have it with them. I carry my Essential Anatomy 5 into all the patients' rooms with me and show them. Patients are ecstatic when you're looking and showing them something on a screen rather than looking at a computer across the room. So that's been fabulous having these apps. And that's supposed to be sorry. Okay, so this is really truly the newest anatomy. I like the one on the right. It shows the fascia, the epimysial fascia, the thin fascia over the muscle bundles is shear, almost shear. Look at the massive amount of connective tissue in this joint. There are 11 ligaments, there are 11 bursae, okay? This is another point. That this is a superimposed rectus femoris over vastus intermedius. And the two tendons join at the bone, at the patella. And this gets into Dr. Antonio Stecco's brilliant work on fascial expansions. To me as a surgeon, the fascial expansions make tremendous sense. And when we do the videos of the injections, I hope you'll agree with me. So what do we do here in this clinic? And we're increasing and we're seeing more complicated patients. We're learning more about things that don't really have treatments yet. We're trying to develop treatments ourselves. We have a portion of the week, 2 days a week, we see patients that have insurance. And I basically have every insurance available to treat patients. And those are non-cash days. So the patient gets a 45-minute to an hour MD evaluation, head to toe, perpetuating factors, nutrition, other medical issues that need to be treated simultaneously, hypertension, heart disease, which we usually get back to the referring physicians, because many of them are very young and have diseases that they've not even seen any other kind of doctor yet. Then the patient has a myofascial trigger point evaluation, and at this point, this is the real crucial issue. It's based largely on referral patterns, almost completely on referral patterns. Then the patient has, I'm sorry about that, let's turn that off. Why don't you just get rid of it?
Okay, sure, Doc, here. Thank you.
Sorry about that.
No worries.
Okay, the patient has has adjunctive therapy, heat. We almost never use cold for anything. I personally don't believe in cold except for an acute injury in the emergency room where you need 24 hours of cold to decrease the inflammation. The patient then has trigger point injections and followed by the myofascial therapy, by the myofascial trigger point therapy by the therapist. I do not any longer do trigger point injections if they're not going to have therapy afterwards. For years, I worked in chiropractic clinics. I did thousands of trigger point injections. We'd inject the patient, rub-a-dub-dub a little bit with some little machine, and they would go home. We have advanced this trigger point treatment probe to a very high degree. I own the term myofascial rejuvenation. I did own this when I presented the first talk in 2017. I'm hoping that we will go more towards this definition of what we really do. And our societies are open and welcome to use this terminology. I just have to have trademark it, and I still own the trademark. Okay, now, what kind of trigger point injections do we use? We use 2 ingredients. One is called the pitcher plant extract, used to be called Serapin, and the other is bupivacaine, very long-acting lidocaine, novocaine. By the way, very little lidocaine, novocaine is used anymore in this country at all because it has a very delayed onset compared to what we used to believe, and it's gone very quickly. Okay, so I make syringes with 3 cc's of pitcher plant extract, 60%, and bupivacaine, 40%. We do not use steroids, virtually ever. I do not use epinephrine, ever. Epinephrine is known for causing vasoconstrictions, the opposite of what we want. And frequently a patient will go home from outpatient surgery having had epinephrine in their local and will bleed later as the vessels open. So I just ignore it. It's vasoactive. I don't want anything to do with it. Our methods, I usually use a cc per trigger point injection. If it's a bursa or somewhere deeper, I'll use several cc's. I use a 10 cc syringe for years with an 1.25 inch needle. My hand almost fell off. I had so much pain in my thenar eminence, my thumb. I switched to 5 cc syringes with a 1/2 inch needle. It works beautifully. It's always as deep enough. I do not stipple the fascia. I do not readjust the needle. I do not believe in repeatedly perforating the fascia. Once through and expand the space with the trigger point injection. So there's no needle readjustment, angling, or repeat puncturing. Here it is. And I think this slide will show you why our patients do so well and tolerate these so well. Very little pain. Even needlephobic patients end up wanting these injections. In the center, you see the 3 bottles. And I've just showed this picture of lidocaine because there was a point at which Serapin was unavailable when COVID first started. And at the same time, there were problems with the sterility or the company that was marketing the Serapin. So for about 6 months, I did not have the pitcher plant extract. And I just had these local anesthetics. Patients had very bad results. They'd come back for a second injection and never want them. That doesn't happen anymore at all. Virtually all of the patients get hooked immediately. I think the reason is because if you look at this bupivacaine, here's a pH chart that read, this is like the very top one, that pH is 4.5. It's extremely acidic. And when we talk about myotoxicity, is this myotoxic? Dr. Travell used procaine, also very acidic. But when you mix the Serapin, if you see this green, if I let this sit a little bit longer, that box will turn completely green. Now we're down to a pH of at least 6, and probably depending on the exact admixture, maybe a little higher. So we're getting near neutral. And I strongly believe that's why I don't see any clinical myotoxicity. I can't prove that. Of course, we don't biopsy these patients. Oops, something's wrong. Let's see. Maybe this will work. There, okay, we'll go back. So there I am, you notice, you're gonna look at this and say, oh my God, this is not sterile technique. I can guarantee you that this is sterile technique. I'm a cardiac surgeon. I know how bad infections are. I have not had any of that. I do not touch the needle. The needle doesn't touch the table. I've got this down to a science. I can draw up a bottle of the pitcher plant and mix with bupivacaine. Probably in about 10 minutes, I can open the syringes and do all that very quickly. And it definitely is sterile technique, even though there are no gloves. And if those who do use gloves don't use sterile gloves anyway, that would be just a complete waste of money. So what is this Serapin stuff? Serapin was used in veterinary medicine since the 1940s for horse laminitis. And I think that's where we get most of the information. Massive amounts of this pitcher plant extract are used in veterinary medicine, especially in these multi-million-dollar racehorses. And the veterinary rules in America allow injection up to 24 hours before the procedure. Now, in my experience, the bupivacaine, lidocaine lasts 8 to 10 hours. So the patient gets excellent therapy by the massage therapist and go much deeper because of the local anesthetic. Then it lasts 8 to 10 hours. So they go home, they don't splint. And then the Serapin seems, the anti-inflammatory effect appears to me to last 3 to 5 days. That's based on the huge number of injections I've done. Its most common uses in medicine are sciatica, intercostal neuritis, these other neuritises, but we use the bulk of ours for myofascial trigger points. Are there any contraindications? I really can't think of any true absolute contraindications. I consider anticoagulation with Eliquis or Coumadin relative, but if it's a very superficial muscle and the patient is really in trouble, I will do an injection. We'll keep the patient for a while afterwards if they're on Eliquis, not probably Coumadin. First trimester of pregnancy, I try to give no medications, but I have had several pregnant patients with severe sacroiliac pain who've come in their second trimester really wanting these. And then of course, needle phobia, but like I said previously, most people get over their needle phobia very quickly when they have their first trigger point injections. So my experience is far greater than 5,000 patient encounters. Now, I'm not talking about 5,000 injections because each patient gets an average of about 5 to 6 injections, some up to 10, especially fibromyalgia patients. I have not had bleeding. I have not had an allergic reaction. I have not had a major side effect like a pneumothorax or a hemopericardium, which rarely occurs with dry needling. Our needle is just too short for any of this to happen. Over 90% are performed with the clinician and the therapist working together in the room and either observing or assisting each other. The benefits, like I said previously, are short-lived when the pitcher plant is not available. 90% for myofascial trigger points and occasional uses for bursas, especially IT, trochanteric area. And I use a lot for intercostal and suboccipital spaces. I do not actually do nerve injections. Even though I'm a cardiothoracic surgeon, I practice as a PM&R physician, and I'm not an anesthesiologist. So I inject spaces. I do not try to nerve blocks themselves. It's a very important consideration. There appears to be very diagnostic and therapeutic benefit for knee osteoarthritis. So when patients cannot have a knee procedure or they aren't a candidate for some reason for hyaluronic acid, we will use this as a diagnostic test because if it works, if the knee is improved after this injection, we can carry them through 4 to 6 weeks, seeing them once a week till they can get to the orthopod to have their procedure. So therefore, it's an excellent temporizing procedure, which we call prehabilitation. We're getting the patient ready for the knee replacement. Actually, some of them don't even need the physical therapy afterwards. So I put this up here because at the bottom it says requesting contributions. That doesn't mean money. Most of these Wikipedia sites, and I always go to Wiki first before I go to PubMed. I want to see what the public knows and is thinking. So Wikipedia in 2021 said pain is perceived at a location other than referred pain as a location other than the stimulus, sometimes referred to as reflective pain, but not in myofascial therapy. There is not a definition of referred pain as of today by the International Association for the Study of Pain. However, the classic definition in this, our specialty in myofascial therapy, is that fascia is a soft tissue component of the connective system, and we will get into showing you how the referral occurs. So angina, phantom limb pain, and mostly myofascial pain are definite referred pains, and Wiki requests more information. So we will try to add some of that after this presentation and after our work in June, to add information. There's very little information on referred pain in what the general public reads. Okay, so I was assigned the knee. This could be true for any other joint, any other area of the body. Look at this. There are 15 areas of referral pain to the knee. So it's not just pain in the knee. It's not just knee pain. It's what part of the knee, where on the knee. And we're going to show you, I just chose the quadriceps group. I could have chose any other. We do them together. I'm going to show you how this works. First, I think I don't need to show that. We've already gone through this pretty much. I just want to make sure that we remember that periosteum is extremely vascular, and I think is a terminal point of the myofascial unit. I'd love to hear what Dr. Steckel says about that. And look at this. There are 11 burses. The 4 peripatellar are the ones that are usually referred to, but there are many, many. And look at how much the entire knee is connective tissue. We haven't even gotten to the muscles yet. And bone is not involved in any of this at all, except in a condition called osteochondritis dissecans, where the bone does crack because of the pressure. But most of these, the bone is not involved. Now, let me show this video. I would have to say that given my surgical history, my history in many other specialties, the most important factor in myofascial therapy is the referral pain component. I have done many, many injections in patients before coming to myofascial trigger point therapy, in which we simply injected the sore spot or the painful spot. But as you can see from these diagrams, far more than 50% of the pain that we treat is referral pain, and we inject the perpetrator rather than the pain itself. I'm going to advance now. Oh, sorry. Can I advance from here? Yes. So we're going to go through the 4 quadriceps muscles that we decided to show you videos of and how we do this. And note this, that the trigger point for this anterior knee pain is far distal. Now remember, the myofascial NMJ in all these muscle fibers is usually in the center of the muscle bundle. I stay away from the tendinous insertions. They're avascular. I don't want to touch them. So I usually try to get closest, somewhere in the middle of this muscle bundle. Now the next is a video of us injecting the rectus femoris, and Mary and I will be working together. Can we show that video? This patient is a bodybuilder, so he was an excellent, excellent person to use for these videos, because you'll be able to
Raise
see.
the leg up, flex and hold. Rotate just a little, good. Drop down. How about there versus there versus there? Ooh, okay, feel it in the knee. So I'll let you palpate there, Doc. I'm gonna ask you to pick it up again.
Now see, I'm up near the tendon now. That's perfect.
Put it down or keep it up?
Keep it up for just a minute. Now I'm going to inject, now lower it. Great. This is showing all the little tricks that I've learned over the years with you that I didn't do before. Can we show the next slide? Perfect. Now I want to point out that during that video, you notice contraction, relaxation. The patient is such a perfect anatomic specimen. I did that specifically to show, I would not need to use that technique on this patient. His muscles are just so obvious, and they're just under the skin, really. But in a patient in whom the muscle is hard to find, diminutive, they definitely have pain, say in the latissimus, using these active techniques makes all the difference in the world. Hand on the head for the latissimus, just many, many motions that we have worked on and developed together. And it's just phenomenal. Now here's the vastus lateralis. Look how many origins of knee pain are in the vastus. I think that's 5 up there, 4, 3, 5 different trigger points. So we're going to show this next one is a vastus lateralis injection for the side of the knee, lateral part of the knee. Next video.
Okay, so I'll be looking here. Any referral here?
To the knee.
Oh, now, okay, extend the knee, straighten. How about right there? Oh, yeah, he definitely
I don't think
feels
they
it
can
there,
hear what I'm
Doc.
saying.
You go ahead.
So since we're going to try to go a little more to this straight.
Okay, straighten the leg, Mike.
Now,
And
this is really important. Contract it, now relax. I want to show that for sure. So can we see how that one turned out? So we run into the rest of them
Needle is that one that goes back
We're done.
into the.
Next slide. Now, in the previous video, you may have heard the patient say when we were putting pressure on the mid muscle, he complained of knee pain. So we were reproducing his knee pain, but we didn't inject anywhere near the knee. Vastus medialis, again, this is pain on the medial side of the knee. The trigger point is as seen in the vastus medialis. Next video. Right there.
Yeah, definitely.
Okay,
That's
down
one.
you palpate.
Exactly.
Straighten that again, give you another one just in case. Straighten that up, Mike. Hold it. Straighten that up. Drop down.
Drop
Not
down.
yet, not yet.
Sorry.
Now drop it.
Let's go loose
Switch
that
there.
goes.
See, I like to inject when it's relaxed.
Did you guys catch that?
Okay, the next slide. This will be the last one. Okay, patient has to be prone for this injection because I'm going to treat biceps femoris. But again, look at how many trigger points there are. And we have to work till we find the one that really causes the referral. And this is posterior knee pain. Okay, this is going to be the last video. And it also points out how important it is to position the patient properly. This will be the last video.
Here, Mike, versus here, Mike. That one or this one? That one.
Yeah, that's good. Yeah, I feel that one.
Then from your deck, I'll get out of the way.
Definitely feel that.
Step in, clean.
Flexure knee a little bit. Perfect. A little bit. Relax. That's it.
Almost Dax's hand in the way.
Okay, back to the slides. Should be able to finish up in a few minutes. After each patient is injected, I make this diagram, it says John Doe. List all the muscles, mark them with X's, and this one actually shows that we've done a little electrical stimulation with microcurrent during the treatment also. Just a good way to, I move a little tab from marker to marker. We don't use electronic medical records here yet, thank God. Okay, why do I think, what do I believe the benefits are? Well, the bupivacaine, as I said, the patient can tolerate much deeper therapy without pain. Can't think of a single patient we've hurt with the bupivacaine. I know that in physical therapy a few years ago, I was informed that local anesthetic was avoided in fear of hurting the patient. We have not seen that. And so the patient doesn't splint and goes home and moves normally for the first 8 to 10 hours. The rest of this, the most important thing here is, are we dealing with a placebo effect? If I used all saline, would I get the same results? I'm really not sure. The only thing I can say is that, like I said, when we didn't have Serapin, when we didn't have pitcher plant extract, the patient really didn't want the injections. So I think it's a combination of the volume. I do believe that there's an anti-inflammatory effect, and that's where I think some research should be done. I think this technique is fantastic, but must be studied more by you basic scientists. I don't live in the lab anymore. Okay, so let's talk about this poor ankle mobility, listed as one of the 10 top causes of knee pain in this country. Well, I do think the foot is a major cause of foot pain in this country, but is it really poor ankle mobility? So we believe that we have a lot of patients, 80% of I'll get into the data later. Plantar fasciitis and overpronation due to Morton's toe. definitely contribute to knee pain and other pains, all kinds of myofascial pain syndromes. So let's get into that just a little bit. Okay. As you notice, this article is in press. It will be published in Practical Pain Management in January. Mary and I have been working on this for a long time. So when we first wrote this paper, we had 214 consecutive patients, so we didn't leave anybody out. That's important. It's not really a highly statistically based study, but it's a good clinical study. We noticed an incidence initially when we first started to aggressively look for this of 60%. Currently, at least 80% of the patients that come to this office for myofascial therapy have Morton's toe. And we correct it. We're not going to get into all that. But anyway, so our findings were that foot pain was very unusual. And those that did have foot pain either had plantar fasciitis or a Morton's neuroma. By the way, for those of you who don't know this area, the two Morton's neuroma, Morton's toe are completely different people. But a Morton's foot structure can cause a Morton's neuroma. They don't need to be operated on. So 17% of the patients had knee pain and 45% have back, hip, and leg pain. And a small percentage have flat feet. And if they're flexible flat feet, we can treat them with an arch that we glue into our insoles. So this is just a couple patients that are very dramatic. This patient on the left here is a very young man in his 20s. Note he has a bunion. Notice he has this deep space here and this shallow space here, and this second toe is longer than the first. Okay, this is predicted. This occurs certainly way more than 50% of Americans. I see some data that says it's much, much higher. And in Japan and Russia, 90%. Now, is the flat foot situation related to Morton's toe or vice versa? Doesn't matter. We see this very frequently. So this foot has to be corrected. And here's how we do. This is a particularly severe patient, a young woman who actually had TMJ syndrome and had surgery for TMJ. This is a well-recognized complication of Morton's foot, Morton's toe. Notice severe ankle collapse. She is just releasing like crazy. Now, when we add this is Mary's job. Mary measures the first metatarsal deficit. I'm not going to get too much into that, but how much too short the first metatarsal is, because that's the whole basis of Morton's toe. And we have an insole that will correct that deficit. And the ankle will then be in what's called subtalar neutral. It's straight up and down. It's no longer collapsing. Weak ankles are almost always due to Morton's toe, what people call weak ankles. And this is just the way it is. This is a very typical x-ray, and this is one of our patients with fibromyalgia and Morton's toe, and obviously overweight. And that medial bone on bone, almost no space in the medial side, but open on the lateral side. This is classic for the patient in America who has knee surgery, knee replacement. Actually, I think this patient eventually went on to have knee replacement because we don't see them until they're very advanced. That's a classic x-ray. Now, sometimes if we're going to treat this patient temporarily with Serapin, we'll inject the lateral space just to give them some relief for a short period of time. So this is the thing. I'm so excited about the fact that when Dr. Karlaseko's book came out, this all made sense with everything I'd been learning, the Vesalius picture from 1543. I think that Padua, University of Padua, is a Sistine Chapel of Fascia. And I'm really hoping that you all decide to attend the meeting. This is an old slide. I don't have a new slide for this. The challenges now are exactly the same as what I presented at the NAMTP in 2017. Correct many, many misconceptions. Increase the visibility, not only of NAMPT, all other fascial treatments. Recruit more therapists, PTs, NPs, or should they recruit more of us? We have to determine the scope of our practices by state to decide whether we should recruit these licensed people. Most importantly, should you add an MD or DO to your practice, or should they add you to their practice? Clearly, we're dramatically under-treating myofascial pain. I hope you've enjoyed this talk. I hope you have some questions and hopefully a lot of criticisms. Thank you very much.
Okay, well, thank you, Dr. Hartz, for such a fascinating presentation. I think it's raised a lot of interest, I'm sure, with the people who are here. For the people who would like to ask questions, this is the time to do it, and you need to do those questions in the chat box. So, what do you think about, Dr. Hartz? What do you think about how to educate doctors who are not as familiar with all of this? Where do we start with doing this? I mean, it's a huge issue, and yet I know there are so many doctors who really don't know anything about this area. So what would be your idea about that?
Well, fortunately for us, I'm Blue Cross Blue Shield Tier 1 in Illinois, and so we see a lot of patients that could not go to a myofascial practice for any other reason. And we need to have a much stronger presence on social media. We just must, especially Facebook and LinkedIn. That's basically what patients see. In preparing for this talk, one day I reviewed 7 different ads for 7 different orthotics on Facebook, none of which works, none of which treats what we believe the way it should be treated. So that's one. We need to increase membership in all these organizations, and we need to work together. American Academy of Pain Management, IMS, NAMTPT. I think that a lot of physicians, retired physicians, would love to do this kind of work. Physicians are leaving practices, as you know, in America, in droves. And surgeons want to die at the operating room table. They haven't even developed enough of a presence in anything else. We can do this. Now, I had a pediatric internship, so I have a little bit of an advantage in learning medicine, but anybody who can do any kind of procedures could be involved in this and have a very nice, retirement sort of transition. There are many physicians who would probably be involved in this.
So Dr. Hartz, you could tell everyone you're developing an education program for physicians in the trigger point injection protocol?
Yes, I'm working on 2 things. I really need to have a course. We've been so busy clinically, and we're really to the point now, though, we've reached critical mass. I want to teach this technique. I've worked on it for 10 years, and I would love to get this together and maybe even have something on it at the meeting in Italy. I don't know, but just to get this all out to the other organizations. And also there's some other issues, some other things that we'd like to make a big presence in. One of them being your area, Ray, fibromyalgia.
Well, yes, and of course, fibromyalgia is always accompanied by myofascial pain, as you well know. I mean, it's part of what goes on. There's other things with fibromyalgia too that need to be addressed, but the myofascial pain is what is causing the pain. So that's important. Okay, how often does vasovagal syncope due to injections occur in your practice? Great presentation, thank you.
I have never had one using these injections. I have had them when I do knee injections with hyaluronic acid when I was in Cairo. And so I got to the point then that I always had the patient on the examining table, semi-recumbent with their knee hanging off the edge of the table. I had a couple of vasovagal reactions back then, but you just have to stimulate the patient. I mean, literally, I hate to say it, but pinch them or something and they come right back. But I've never had one doing myofascial trigger point injections. Haven't had one.
This one is, this is from Sarah Ernest Edwards. I think you may have touched on this, but can you say again why you don't inject exactly where the myofascial trigger point taut band is palpated? For example, in your videos on the vastus lateralis injections, is it close enough for the bupivacaine to be effective? You can tell I'm not medical. Thank you for all your work in this area.
Thank you. This is exactly the point of the entire presentation. We inject the perpetrator. We examine the patient till we feel that taut band and it's painful, okay? The referral knee pain goes away. We are really almost always injecting directly in the center of the distance between the perpetrator and the victim, between the middle of the vastus med and the medial knee? That's a very good question, and it really underlies everything we do.
May I, Dr. Hartz?
Yeah, Mary has some stuff to say, and it's important.
So Dr. Hartz, also in what she had said in her presentation was that she doesn't inject near the tendon, but yes, of course, that's what we're all palpating for. I, as the trigger point therapist, under doctor's direction, will go through the fibers. We will ask the patient if it hurts or is discomforting, or if they have a referral. And then doctor will go in. But what she had said was she doesn't inject near the tendons very often. Next question.
Thank you for that question.
Do you think that there is a dichotomy of thought and treatment in the field of myofascial pain between treating the muscle, e.g. the cone technique of injection, and the fascia, your atomatic technique? This is Dr. Sorrell.
I don't know what the cone technique is. Could I have an explanation, Mary? Do you understand what the cone technique is?
I do not.
I have not read that.
Okay.
And actually, I have to say, my technique isn't 100% atraumatic. I mean, I do traumatize, but I try one stick, clean, inject, don't move the needle around. I make it as atraumatic as possible. But I don't know what the cone technique is, but when I learned, we were stippling, we were moving the needle around. It was very painful. So I don't do that anymore.
Okay.
Does that answer the question?
Okay. All right. If there's some more questions, or if there are more questions, we'll be glad to take them. We've got a few more minutes, and then we'll be letting all of you go. And while we're waiting for maybe another question, I just want you to know I thank you for participating in this myofascial pain webinar. Now join us on November 18th for the next webinar, when Dr. Preeti Bragahaven will present hyaluronan and muscle stiffness. Thank you. So thank you, Dr.
Can I say one more thing about this hyaluronan?
Oh, absolutely. Go ahead.
I believe that we are diluting the hyaluron. I think that what Dr. Steckel calls densification, we would call viscosity in surgery. And that's why I asked the question, raised the issue, this needs to be studied in a lab, because are we getting a placebo effect? Could we use saline and get the same dilution of the hyaluronic acid? Okay. So I might get the hyaluronic acid a little bit backwards, but we're talking about viscosity, and are we just diluting the area? I don't think so. I personally have done so many in so many different ways that I do really believe we're giving an anti-inflammatory effect. So.
Okay. There was another, there's a comment here from Dr. Sorrell that has to do with the cone. Just a second here.
Great.
And the cone technique is the usual method Dr. Gerwin and Dr. Sorrell use, which you may call stippling. Does that make any difference? Mary, do you know?
Yeah, that makes, now I understand. I understand what you're saying.
Okay, gotcha.
No, I'm sorry, but I did that for years. That's the way I trained. It's more painful to the patient. It's more like, well, I would say that the mechanism of dry needling is central nervous, spinal cord, brain. I believe that our technique is purely local treatment. I want one stick, I want a clean stick. I want it to be minimally traumatic. My point is not to make holes in the fascia. My point is just to get the needle through the fascia as painlessly as possible, and then inject my components. But again, a lot of these people I don't know, Dr. Gerwin, if Dr. Gerwin and you use just local anesthetic, but I just don't do that.
Well, if there are no more questions, we will bring this to a close. And thank you again for a wonderful presentation, Dr. Hartz. Thank you.
And thank you for having us part of this fantastic organization.
We're glad to have you. We need you. Okay. And I've closed this off by already making the announcement for the next webinar on November 18th. So thank you.